Talked about dosing of intravenous vitamin C. Now we have different focus. Now, when many years ago, Dr. Gonzales and I started working with intravenous vitamin C, we knew we were into something that might be of great interest, but we faced opposition from medical establishment there in Puerto Rico. And in fact, we even face opposition getting funds and in many ways that we were trying to do research. So one of the things we say is that we should, in order to gain more confidence from people who are not used to vitamin C and give the opportunity to the patients, we should look into other areas that are less ambitious, like improving symptoms, like therapy that will help the main therapy. And along those lines, we've seen that, in fact, vitamin C and other nutrients can be given along with chemotherapy and radiation, and they actually decrease lots of side effects. And we've seen many interesting things that haven't been reported much, like decreased pain and so on. Well, when you look into the cause of death of people who have cancer, a lot of time it's not the cancer, the tumor, like pressing something and causing death, but another complication with the immune system or an infection. So today we're talking about intravenous vitamin C and sepsis in the cancer patient. And I don't know if okay, here we go. So in the previous conference, we're speaking about the cancer patient having a low vitamin C concentration to begin with. And that's something that we'll talk a little bit today now. So we're going to talk about the benefits of intravenous vitamin C with cancer-associated inflammation and some specific consequences like systemic inflammatory response syndrome, or SIRS, and multi-organ failure. And also, vitamin C enhancing quality of life, although there's a couple of studies that have looked into this. We're not going to review them, but we'll mention them. There's some reference over there in which we look into or establish that advanced cancer patients have low vitamin C levels. And in top of that, when they get certain injuries or infections like sepsis, the vitamin C level decrease even more. And I put a bullet over there mentioning that 12 patients supplemented while they have some kind of trauma or infection were given increases doses of vitamin C, and they didn't increase their concentration until substantial doses were increased. Like initially they were given 300 and they wouldn't respond, then they were given 1,000, they wouldn't respond, and they had to give like 3,000 several times so that they would raise some kind of level. Now, the USDA Agricultural Research Service had published certain guidelines for interpretations of vitamin C, and they say that if a person would have a plasma concentration below 11.1 micromoles, it would be deficient. If it was between 11.1 and 23, it would be low, and if it's above 23 micromoles, it would be adequate. So I'm using this as a reference because when you have other studies talking about what is deficient or low or adequate, they will use this as a reference. There was a publication in 2005 in palliative medicine in which they look into 50 patients that had cancer, male and female with advanced cancer, average age of 65, and they have a low intake of vitamin C, mostly through diet. And what they found was that 30% were deficient and 42% were low. So most of the people were in trouble with vitamin C. So why do we want vitamin C? Well, it helps endothelial structure, and endothelial is going to be important in the septic syndrome when we're talking about that. It does suppress inflammatory markers, and that had been said before during the conference. Protects from sepsis, at least in animal models, has anti-neoplastic effects, you all know that, and it has a remarkable safety record. A couple of years ago, the group from Padayati reported many thousands of doses of intravenous vitamin C given in the year 2006 and 2008, and that particular publication showed a remarkable safety of intravenous vitamin C. So that's why we're proposing that vitamin C should be used as an adjuvant to existing modalities in the treatment of prevention of cancer-associated sepsis, because when you look at the way it's handled right now, it's mostly symptomatic. There's different severities of inflammation in the cancer patient, and you can go from the chronic low-level inflammation response to the acute and very severe inflammation. When you look at the chronic end, the persistent low-grade inflammation will cause a variety of pathophysiologies. The most profound is cachexia. And when you look at this patient, they have poor surgical outcomes. So this is like building up the concept that you have many reasons to give vitamin C in order to help the patients. The acute inflammation that is observed in these patients, the acute systemic inflammatory response syndrome, is a major cause of death in cancer patients, especially those who have hematological malignancies. And this is a reaction to severe clinical insults. It's caused by infections or trauma, and it goes very close to what is sepsis, because the only difference is when you document that you have an infection. And this is more like a continuum. You know, people who have cancer, trauma, burns, pancreatitis, prime the body to go into the syndrome, and if the microbes that are exposed to these patients actually infect him, he goes into sepsis, and the sepsis could go into septic syndrome and septic shock, which is this continuum that I'm showing here. Obviously, increasing severity and increasing risk of death. So this, if you have two of the criteria, and when you look at these criteria are the same criteria of the septic syndrome, if you have two of those, then you know you have the systemic inflammatory response that presents on the cancer patient. So if you have an active infection, then it's sepsis. And obviously, if it's affecting the patient's systolic blood pressure, then you go into shock. The patient is into shock. So we have inflammatory responses that could eventually affect the clotting cascade and the complement activation, and that's when you go to multiple organ failure. which is more severe. So you got these inflammatory cytokines, the hemostatic system is altered, and it also affects the endothelial system. It's got clogged, and therefore the organs all get affected. So when you have a patient with severe sepsis, mortality rate is very high, and you have a lot of oxidative stress, clotting factors causing a lot of problem, and capillary plugging. This sepsis may be developed by surgery, pneumonia, and substitute infection, which is associated in this patient with malignancies. Now, if it's more chronic, like in the case of people with cachexia, you'll see that people with SIRT and are cachectic has a high rate of percentage of people who have both. And in this situation, tumors themselves, through an interaction to the host, generate a lot of mediators like interleukin-1, 6, tumoral necrosis factor, which produce this inflammatory reaction. And the thing is that it's mostly treated by support measures. Now, since this causes dysfunction of the inflammatory microcirculatory system, and in the most advanced stages could manifest as disseminated intravascular coagulation when it's turning to multi-organ failure. You got to think what else besides giving fluids to the patients and trying to give pressure support can we give? Well, there's some papers that says that ascorbic acid can mediate a beneficial effect to the endothelial cells, especially in the chronic context. And this is where it all comes together, because ascorbic acid can produce an important effect.
So, folks, what if I get this to work? You can hear me?
Hey.
Well, the thing is, we're talking about a hell lot of infection here. So how can ascorbic acid help? Ascorbic acid could help in various ways. One of them is that you will have, in the presence of ascorbic acid, you may have higher levels of nitric oxide, because we know that ascorbic acid will protect nitric oxide from degradation by the free radicals. There's other disruptions that occur in SIRS. That's there's the endothelial cell apoptosis is disrupted, the regulation of adhesion molecules, the procoagulant state, and all these issues have been reported to be modulated by ascorbic acid. It's important to identify the real effective route of how this ascorbic acid will help. And we've seen that oral appears not to have major effects. Although with the oral issue, there are some reports by Hickey that he has a dynamic flow model in where oral administration has been shown to be capable of reaching therapeutic levels. But, taking 2 or 3 grams of vitamin C every hour, every 2 hours is probably not too practical. There's another option that will be the liposomal vitamin C that may have a better effect than just the oral plain ascorbic acid. But in general, we have seen that these high inflammation type of conditions, it will respond well to IV vitamin C. And there's numerous inflammatory conditions, gastritis, pancreatitis, diabetes, rheumatoid arthritis, all associated with diminished plasma levels of ascorbic acid. Also, these reductions in ascorbic acid have been observed in SIRS patients in ICU, And it's a very interesting demonstration that some studies have shown. It's that it's a correlation between plasma ascorbic acid and survival. So if the less ascorbic acid, the less survival. So it's important. We have seen that cancer patients exhibit a general state of chronic inflammation, and this could get worse when you apply certain therapies like chemotherapy and radiation, that you may invite the environment for these bacteria and viruses to come in. And this will really create this problem with the sears and the other continuum of deterioration of the physiology. So we see that the markers of elevation are, of inflammation are elevated. And this is associated also with poor survival. You could see that CRP, homocysteine, IL-6, free radicals in general are increased. We have seen there's enough information of the benefit of ascorbic acid in benefiting the quality of life of cancer patients. I think if something that we could guarantee with using ascorbic acid, it's probably that, the benefit in quality of life. We can't guarantee other issues, but maybe that one is one that we have sufficient information and sufficient evidence to know that most of the people benefit at least at that term with ascorbic acid. Well, we have talked about the different and direct anti-cancer effects, some improvements in mitochondrial function, restoration of oxidative respiration, and also there's a physical type of benefit in increased formation of collagen barrier that may help prevent metastasis. Also, we have seen that these cytotoxic or maybe carcinostatic effects can be achieved in concentrations available in normal physiology when you give high doses. There have been enhancement of certain cytotoxicity of certain chemotherapeutic agents, and we have seen in vivo and vitro effects of anti-cancer effects that we mentioned that throughout the conference. And there's some reports of clinical remission, even when given vitamin C. No, I'm kidding. Other aspects that has been reported even here by the center by Neil has been inhibition of angiogenesis by Nina also. And that's another possible mechanism of activity of ascorbic acid. So we can see that the potential for benefit of ascorbic acid is substantial. And remember, it's cheap and it's safe. So we could see that cancer patients can benefit of reduction of inflammation, improvement of quality of life, reduction of SIRS, and inhibition of progression to the multiple organ failure. And the thing is that there have been many controversies with vitamin C, but we have to see that it's even with the controversies, we have seen benefits as an adjuvant in therapy cancer treatment, not only to attack the cancer per se, but the environment, the pathological environment that surrounds this condition. There's some key references here. There's one important article by Aicham and Neil and us that came in the Journal of Translational Medicine. There's another article fairly recent by Wilson and Sikor and et al. And I'm done.
Before, can you hear me? Yeah.
Okay. So as I began the initial concepts in the talk, I was saying in cancer therapy, we have protocols, we have a standard of therapy and so on. But what do we have here? Support measures. And we actually know vitamin C is very low in these patients. This is more complicated when we have sepsis. So it's something that we ought to look at. We have to actually do more research, but it's an opportunity that we have to give to the patients. So with that, we're open to questions. Sure.
in the Australian literature, it shows that the angiogenesis of the cancer cells, they do not have any endothelium. Okay? So when the vessels are formed from angiogenesis, they have no endothelium. And you mentioned, one of you gentlemen mentioned that it causes apoptosis of the endothelium in the neovascularization, the neovascular vessels. So if the endothelium is not there, how can it cause apoptosis?
Well, that could be the case in that particular study, but there have been several other models that have actually shown inhibition of angiogenesis. When you compare the action of either vitamin C, well, there's other products that do that too. But there's a couple of studies looking into that, and the intervention of vitamin C can actually inhibit it.
There's one important thing. We have to
angiogenesis.
take into consideration dosing here, because when you're talking about that, when we're talking about the inhibition of angiogenesis, it's kind of pro-oxidant effect. So it's effect in high doses. When you're talking about that sort of inhibition, it's sort of an antioxidant type of
Yeah, but when I'm talking about angiogenesis, I'm talking about the endothelial apoptosis that you gentlemen mentioned. And if they don't have any endothelium, then obviously there's nothing to destroy there, is there?
Okay, but here we're talking about the general effect of the inflammation of the generalized systemic inflammation syndrome. So it's not in terms of just the neovascularization of cancer, but the effects of disseminated intravascular coagulopathy and all those complications related to that particular inflammation syndrome.
Okay.
Not this. Go to the questions of the panel questions.
There's some questions.
Wait, just a second.
Hi, sorry, I don't think it was presented. What dose was used for DIC? What dose were you using? Probably
Disseminated
mild dosing,
intravascular
right?
coagulopathy.
Like 25 grams or something?
Most of the studies have done in animal models, but the issues in humans, it's been doses between 50 and 100 grams. You know, it's really, at least in the ones that I have seen, they use that dosing. If the person is really weak, I think you should go slowly increasing the dosing till you reach whatever dose level you're able to reach.
I think in his book he was showing that the patient who had SARS, they built it up to 100, and that's when it cleared SARS.
I think in every patient, even if it's strong enough, you have to go building up.
Building up,
Yeah.
yeah, that's what I'm saying.
Here we're looking at two possibilities, like the more acute severe inflammation versus the more chronic. And in most of the cases, you'd like to think that you're going to treat the patient before the very acute event occurs, so that you don't have this acute event and it's going to be difficult to manage. So you'd like to think that you're taking care of the situation before it actually becomes too difficult to manage. And since this is more of, we're thinking in the patient that has been diagnosed with cancer and is becoming this increasing inflammation syndrome. And what you want to do is start supplying enough vitamin C. You see, they're not a good amount of studies that have looked into this. It's like only a few studies. If you look into the literature of sepsis and inflammation and so on, so you need to think, okay, let's give them the vitamin C for supplying all this deficiency plus enough to build up his stores, the levels, giving opportunity to treat the vitamin C. So you go
Yeah, but my question was more related to the actual acute situation when that happened and you have to interfere, and that was the question. Probably just that with
Excuse me?
25. My question was related more to the acute occurrence and what you need to do to treat the patient acutely. And I guess
Acutely.
I answered my own question, 25 and build up to 100. Yeah, thank you.
Well, you know, the interesting thing is here is that once you start increasing the levels that you apply, you start seeing different mechanisms taking place. You have the increased collagen formation. You have the increased activation of the white blood cells. You have certain inhibition of certain reactive species. So you see these falling in place once you start getting these levels up in these patients. So they start getting better slowly, but firmly, you know. So I don't know if that answers your question.
In the question that you have in mind, would this be a patient that is naive to vitamin C? Because you got to consider certain things. If you've never given and you don't know if it's GP deficient, and you should start getting the G6PD to make sure that you can give it. But in the acute, obviously, if the patient is acute, you got to be more aggressive because these people can die easily. So that means trying to move quickly to give a substantial dose that would go maybe 25, 50 grams in that range, I would say.
Do you worry about osmolarity? What osmolarity?
There's a mic here.
What what osmolarities do you like to go up to in your peripheral veins?
Well, most of the people who use intravenous vitamin C are always using hyperosmolar preparations. If I have the chance, if I can choose, if it's not very acute, I try to go as gentle as possible, so the more diluted, the better.
The thing here is that we publish a paper in that we talk about the specific of the osmolarity, but in reality, we don't pay that much attention to it, and I'll tell you why. The thing is, we try to go the highest that we can and that it's effective for the patient. But at the same time, what we always do is have them hydrated. That's very important. So we give them water. We have them piles of water, and you have to have a bathroom near because you're going to have, you can't imagine how many peers you're going to have. So, but we don't worry that much. They're going to get thirsty. I mean, once you go probably over 75 grams, they're going to get really thirsty. Just give them water, and they'll be okay.
Why not dilute it so you don't go over, say, 700 or so on your osmolarity and just give them more fluids? Dilute it more and give them more. Then you don't have, then you're...
If the person can handle the water, it's fine with me. I mean, I kind of like the closer I can get to isosmolarity, I think the better it is. Sometimes it's difficult with some patients, but I do. That's my tendency.
Yeah, the general rule is not more than 2 times osmolarity, maybe 3 for a peripheral vein, and so. But I see this violated so much, and as an ex-anesthesiologist and somebody who's going to be giving repeated IVs, that's really hard on veins.
Yes, and you can have other metabolic abnormalities. So I agree with you.
Yeah, that's why we use the intermittent more than the continuous.
Questions there? Tell me when we're over, because I want to play the gong. I haven't had the chance yet.
You've been gone.
Sorry. Very quickly, along those same lines, do you want to make any kind of comment about pH of your IV solution?
Michael.
That's a good question. We've been playing with that, and sometimes it seems to be, we have measured sometimes, it seems to be low, very low. Sometimes it doesn't seem to be that low. We use ringers most of the time, and that helps a lot to maintain it kind of in a physiological rate. But still, we most of the time go a little bit lower than that. And the thing is that, you have any comments? Sometimes we add, we haven't had much problems when we are between 50 and 75. More than that, we may have some trouble with the pH. But we add the magnesium chloride, and we haven't had we haven't had much trouble with that. I don't know what's experienced with the doctor from the KU, Garrett. Garrett, is Garrett here?
He's in the next room.
Oh, okay. But maybe he could mention what his experience with that. Oh, there's Garrett. Come save me. Garrett, there's a question on the pH, on the IV solutions.
I heard the question. Yeah, we don't pay attention much to the pH either, and I have had on our agenda, we have a weekly discussion with some of the other people around the medical center, and that's an interesting question because we don't really follow it at all, and I don't really get into, it doesn't seem like the pH.
If it stings. If it doesn't sting, we're okay.
Yeah, once we get over 50 grams, we don't use the lactated ringers anymore, but we go to the sterile water, and that helps with the osmolality or osmolarity. But yeah, I just try to just allow them to drink freely, and that usually, you know, we don't get into much trouble. And even going with 100 grams in the peripheral IV, even 125 sometimes in the peripheral IV, they don't seem to have a problem with it. It doesn't seem to, and we have given the same individuals infusion after infusion.
Any more questions for Jorge or Michael or anyone else?
Can I play the gong?
We've been gonged.